which many people consider the cornerstone and founding of palliative care movement. And one of the beauties of this conference is our closing speaker, tomorrow, Betty Farrell, wrote The Nature of Suffering and the Goals of Nursing. But Dr. Cassell retired a few years ago from active practice after 37 years in internal medicine. But he continues to write about the problems in medicine, the care of dying, and the nature of suffering, and is an active teacher and leader around the world. He lives in both rural Pennsylvania and Brooklyn, New York, so we're really honored to have him here today. And just want to say thank you.
You know, people always say I'm happy to be here. Well, where I live is the only house on the top of a very steep hill, which has now got 14 inches of snow on it. And when that happens, we don't get out until the road is less slippery, so we would be there for a few days. Even though the guy plows it, it's still slightly icy and all that stuff. But I am happy to be here, and it's such an impressive-looking room, I tell you. You know, when people have groups, and well, there's some that have a better feel and a better vibes, I think is what it's called. And this is that. It's really very impressive. So congratulations to you all for being who you are. I started to take care of the dying actively. I mean, where dying was the diagnosis in 1971. There were no hospices, specialized services or nurses or anything like that. A patient of mine, a nurse whose daughter had died of Hodgkin's disease, became my nurse, and together... Well, you know, I really wanted a lavalier mic because I like to walk around. And I got an email that said there was a lavalier mic and all of that stuff, but I don't see it. So thank you very much. When I walk away from it again, somebody yell, "Microphone!" and I'll get the point. Anyway, so between the two of us, we took care of an increasing number of dying patients because people would refer slowly at first, but we began to get referrals and so forth. People would ask me, "Why do you want to take care of the dying? That must be so difficult." But I said, well, it is, but you know, the feelings are so real. It's real. There's no nonsense about it. It is what it is, and it is really a thing. And the other thing that's sort of strange is I always felt like I was a doctor when I was with those patients. I know that sounds odd, but because I am one, my boy, I am one. And I'll be one till the moment I die, and probably afterwards. Why are you doing that? Anyway, why is it? We have the question is, why is the care of the dying increasing, and why did it then invite doctors to come along? The simple explanation always is that people are professionals and they want to do what they went into medicine to do, which was to take care of people. So it happened that in 1995, I gave a lecture to the annual meeting of what was called the International Hospice Institute, which was founded by a very tough lady named Joe Mangos, an oncologist from the Philippines who was working in New York. Anyway, we had 300 members. It was a wonderful meeting, and that's right. Within a couple of years, there were 3,000. And now the Academy of Hospice Medicine has 5,000, and it probably would, and there are probably several thousand more doing this medicine. So one of the things that is important is, why did they come into medicine? Why have they come into palliative care? And as I said, I think it's because You know, when you go to your interview in medicine, you're supposed to ask you why do you want to go to medical school, and you know not to be so unsophisticated as to say because I like to take care of people, but in fact that's the answer most people would give, and that in fact is the answer I gave because I really wasn't very sophisticated, but I did even then want to take care of people, and that's what we do. And so we look around in the rest of medicine. And we see that despite the wonders of science and the almost magic of much of the technology, and it really is, often because of this, doctors are further distanced from their patients and have removed themselves than at any time in recent history. It has been repeatedly documented that younger doctors have lost the skills of the basic clinical method, which is the connection to the patient, in taking a history and doing a physical examination. I want to tell you that many young doctors cannot do a physical examination. They don't know why they should use a stethoscope because there is another technology for doing that. And so we're seeing a generation of physicians that has lost this sense of being the doctor, not doing a doctor's work, but being the doctor. And they certainly have forgotten that because to most of them, they don't realize how important it is that they have a relationship with this patient they take care of. Who the doctor is really matters. Now, I have to say something. You know, I talk doctor because I'm a doctor. But we all know that now medicine, increasingly, there are many, many people in many different skills who take care of patients. And much of what I say about relationships applies to everybody who has continued contact with a patient. So if I don't mention nursing or physical therapist, whatever, please don't be offended. I'm a doctor and that's who I am, so that's who I can talk from. I can't talk for anybody else. Now, so the relationship between the patient is very important, and so is the relationship, as I said, between the doctor and the patient and many others. And all that I discuss is very important to realize that medicine is not a science. It is a science-using profession. If there was no science, there wouldn't be any medicine, like you know it. But it isn't a science. Medicine, clinical medicine, the care of the sick takes place in an interaction between doctor and patient in a very strange and very difficult to understand, I believe, almost magical interpersonal relationship. Now, of course, this is California, so there's nothing strange about it, but and I think that the same phenomenon is present in every culture in which there is this healing, relationship. We have to ask, why has medicine seemed to become an impersonal science, a scientific transaction between independent, autonomous, knowledgeable patients and physicians bearing scientific diagnoses and treatment? Well, I think three things have happened that have seriously damaged medicine and a lot of other things in our society, especially since the Second World War. The first is the social dominance of science. The science has reached everywhere into our culture, from business to nursery schools. People talk about evidence-based teaching in nursery schools. Well, that's nice. And I'm sure people get evidence and all of that stuff, and they should. You shouldn't just do things in the dark or in the blind, but people who are experienced have reasons for what they do. But they're not talking about that. They talk about science. Science in the nursery school, science in business, science in everywhere you can possibly look. Now, the good of science is undeniable, but like the sorcerer's apprentice, it has lost knowledge of its limits. It doesn't know what its limits are. It has swept aside the personal and the interpersonal. I was taught in the 1950s that who the doctor was did not matter. that it was the science that diagnosed and treated patients. It was nonsense then, and it's nonsense now. But everybody believes that. You know, you can look around. You can look around in this small town in which I live. There are all kinds of convenience facilities. Doc in the box. You know, the immediate medical care, wherever you want. There's so much immediate medical care that I wonder how anybody gets any work done. But that tells you something. That tells you that you think the person who goes there thinks that it's the knowledge that does it and the technology. It doesn't matter who the doctor is. They don't know who those doctors are. But they accept the fact that knowledge is there, and they can go. It doesn't matter. That's what does the work. So remember that this is a very big thing, and if you look around you, you'll see that's what's happened. Now, with that has come the dominance of the objective and objectivity. It cannot be proven objectively. It doesn't exist. Measurement matters. You cannot measure something. Too many people believe it doesn't matter. Too many, ask and these, you know. Thank you very much. And does it work? Good. It's so much better than that. The put down of subjectivity and much of what we know about people and groups and even ourselves. The put down of subjectivity, as though because it's subjective it doesn't count. Everything that's important in your life, except maybe how much money you have in the bank, is subjective. It's how you feel, what you know about something, what you see, what you touch, what you so forth and so on. The put down is really considerable, and because of that, we don't know, I think we actually know less about people and individual persons than we did in the 1970s, because understanding persons involves subjective information, emotions, feelings, thoughts, dreams, interpersonal relationships, and they all depend on subjective matters, subjective knowledge, subjectivity. And the subjective, I think, is one of the things that we'll see coming in the decades to come, decades, not years, to come, is how subjectivity begins to get back its importance and we begin to understand it better. Anyway, so subjectivity is out. And also the fact is that nowadays almost all medicine is taught by faculty for whom practicing medicine, that is taking care of patients, is of secondary importance next to their scientific research. So that students are taught by people who don't do the thing that they teach. And they wouldn't think that that was odd because they don't think the thing that they teach is that important. What they think is important is the science that they're doing. Okay, enough about that. The second thing is, everything is a business. And that is really true maybe in the last 25 years. Everything is a business. And businesses are measured by their profits and losses, by money. How much is made and how much is lost, and how to make sure and how to make more, and how to make sure that the business makes money. Hospitals, universities, even private schools. I saw a thing about private colleges recently, for-profit colleges. It's a business. Somebody whose name I promised I wouldn't mention ran one of those things, and because he sure has fucked up a lot of things, and we have just started. Now, hospitals are a good example. When I started working in French Hospital, which was a small hospital in New York City, that's where the faculty of NYU took their patients, there was an administrator, there was a president of the hospital, a hired, and his job was to take care of the hospital, run the hospital. And he and the sisters of, Sisters Marionette, something like that, he and they ran that hospital. And if you want a clean hospital, an order of nuns is the way you do it. Even though that hospital was run by the French Benevolent Society, which was a Jewish organization, but they were smart enough to hire the nuns. Anyway, hospitals, they were always short of money, and they depended on contributions, but they were humanitarian institutions, and they were proud of their mission, and they concentrated on that mission. Now hospitals, New York Hospital is my hospital, and it's a wonderful hospital. And it used to have a president and the same kind of thing, and they never had any money, and they couldn't have administrators. Now they have large administrations who are paid big salaries. I'm embarrassed to tell you what the salary of the president of New York Hospital is, because it's supposed to be a nonprofit institution. Well, that's in the loosest sense of the word. The hospital makes money. Hospitals, healthcare centers buy and sell other hospitals, and doctors' practices, like businesses, buy and sell other businesses. In Stroudsburg, where I live, the doctors were in groups. They had nice groups. Then the hospital bought the groups. Pocono Medical Center bought the groups. And it used to be Monroe County Hospital, Monroe County Hospital. Now it's Pocono Medical Center. Anyway, they bought the groups. Then along came St. Luke's Medical Center, and it bought the groups from Pocono Hospital. And then along came Lehigh Valley Medical, whatever it is, and they bought Pocono Center Hospital. So St. Luke's owns the doctors, Lehigh Valley owns the hospital, and I don't know who owns their souls, but whatever. And all these things are related, interrelated. The dominance of science and objectivity, money and everything, and the rise of business. Now, you know, this is the world we live in, and it has provided many, many benefits to many, many people. So you can't just say, oh, that's terrible. You can't say that, because somebody would counter that by, yeah, but look at this, and then look at that, and look at that. So it's a complex change in the world, but it is a very big change when it comes to medicine. So why the rise in palliative care in the face of all this? Palliative care, incidentally, the name invented by Balfour-Mount, my hero Balfour-Mount. Balfour-Mount is so special and so wonderful. And boy, I don't say that about a lot of people, I have to tell you. But Balfour-Mount is really special. So he gave it the name. He said Cecily Saunders didn't like the name at all, but I thought it was a good name anyway, so that's the name. So he made it palliative care. It's palliative care, and now it's a board specialty and so forth. So why the rise? Well, it's impossible to remove the interpersonal relationship between staff and patient and between staff itself and still have palliative care. So the relationship has to be important. Palliative care doesn't make a lot of money. I know that makes administrators unhappy about things, because they're going to be always short of money, just like administrators always were. That's their job, is to be short of money and worry about it. My job was to take care of patients and worry about what I did wrong. And people involved care about their patients as they did in the old days. Volunteers are a vital part of palliative care and hospices. They're not nice to have. If it weren't for the volunteers, it wouldn't be the specialty it is. And that's very important. Finally, dying patients are not good objects of science. For one thing, they're muddy. We want a case where you know what the diagnosis is, it's perfectly clear, this is what they have, and you can enter them into a study. You can't hear some poor guy dying of, I don't know, carcinoma of the esophagus into a study, because he has 6 other things as well. He just, so the fact that they're like that, they just don't fit as well. And besides which, a lot of them are old, and you know about old. So, and then the other thing is that subjective things matter, and they openly matter. You know, they fill the environment. Subjectivity fills the environment. We don't call it that. We call it feelings, sentiments, emotions, stories, families, relationships. And those are the things we like. They're a pain in the ass sometimes when you're taking care of somebody and you wish they didn't have such a big family, but all of whom want to be the one in charge independently of all the other ones. But the fact of it is everybody loves it this way, and it makes things personal. So how can palliative care improve the sickness that afflicts medicine? The sickness. Now, to me, medicine, and I say medicine, a culture with poor medicine, to me, is a impoverished culture. Why? Because, you know, that although you have a tough time knowing as you listen to television and all that stuff that anybody is sick in the world, it's kind of funny because, you know, for the ads, you get ads for drugs that cost $10,000 a dose. And they're giving ads on TV like, you know, tell your doctor about, like your doctor doesn't know. Well, of course he knows. That's not tell your doctor, that's push your doctor into using. So he'll use this stuff that costs $10,000 a dose. It probably is expensive to make. It probably costs maybe $1,000 a dose to make or something like that. Anyway, the point is that medicine is important to us. So even though nobody is sick in the world, in fact, we have more sick people than we ever had because people live longer with bad diseases. Things have become chronic that used to be acute. You know, a person used to have advanced breast cancer, everybody was sad and they were dead. And that's just the way it was, you know. And if you wanted to do work with the dying, you could pick someone with stage 4 breast cancer and be reasonably assured that within a year or two she'd be dead. So that was, now, you know, that's because doctors are all hard-hearted, but in fact, it was an acute disease. Now, the palliative care does these 4 things. First of all, it relieves symptoms and suffering. It relieves symptoms and suffering. You can't be in palliative care, you can't do hospice medicine, you can't any of that without being aware that you must make people feel better. You simply must. Pain is a terrible thing. Bad pain is terrible. Bad pain erases everything. Nothing else matters. If pain is bad enough, nothing else matters. So one thing we have to teach is how important symptoms are, because we were all trained as though the symptoms were the throwaway stuff. It was a disease account. The second thing is put the relationship back. Remember, we're teaching medicine. Put the relationship between the doctor and patient back into the center of medicine. Change the focus from disease and disease-related abnormalities to a focus on function. Now, and the patient's ability to achieve goals and purposes. That's what you get up in the morning to do. That's what you get to bed wondering if you have done. And whether you've done what it was you intended to do, and if you can do all those things, you have well-being, even if you're sick. And it is about time that that came back. Make the sick person and not the disease the central concern. The person, now of course, all of you who've read the stuff I write think, you know, that's all I care about. Well, that's not too far from wrong, actually. It's all I care about. The only thing is, as the years have gone by, what I know about being a person has gotten bigger and bigger and bigger and bigger, and so to me it's gotten more important. So let's go back and look at these things more importantly. We know how to relieve pain. Palliative care not only knows how to relieve pain and other symptoms, but we know how important it is. We know how to identify and relieve suffering. Suffering is suffering is suffering is suffering. It's not another thing. It's not the death anxiety. It's not, oh, I don't know, whatever. You got the point. Don't let people tell you about the different kinds of suffering. That's nonsense, because they only tell you that so the insurance company won't pay for existential suffering, but they'll pay for suffering from the body. Oh, That's interesting. Suffering is suffering is suffering and suffering. Whatever happens to one part happens to the whole. It doesn't matter who you are. If your foot is bad, then so are you. Period. And that's the way it has to be. And incidentally, if you're bad, so is your foot. It goes the other way around. Now, my wife, who was somewhere out there, where? There you are, my wonderful wife. My wonderful, wonderful wife. Anyway, now I forgot what I was going to say. Oh, I know what it is. What do they do to the bottom of your foot? What's that called? Oh, so reflexology, which I used to make fun of, but of course, if what I say is true, I can't make fun of it. If we're all of a part, whatever you do to one part, you do to the whole, that puts reflexology back in. Okay, so finally we know that, and we want to get that into medicine. A person who is sick and burdened down with symptoms is a slave to their sickness, and until that's relieved, you won't make them better. And incidentally, you can cure their disease. If they still have symptoms, they're still sick. I just got a telephone call this morning from a patient's daughter asking me, the mother called the doctor because she had a carcinoma of the ovary and she responded to treatment and she's been doing well and she has a pain in her abdomen. He said in the telephone call, and it sounds perfectly reasonable that he would say that, well, maybe it's worse than we think it is. And that was the end of the telephone call. What do you think that did to her? You know, so what should she do? I said, you shouldn't call, and your brother shouldn't call the doctor. Your mother should call the doctor and tell him that he's scared her to death. And what is the real matter? Because whatever it is, the imagination is a lot worse than the thing itself. The thing itself can only kill you. The imagination is even worse than that. Because all the way down to the bottom, you're sick, 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 without knowing why, and that's a terrible thing. Anyway. Boy, move along, Doc. Treat the illness and not just a disease. All terminal or fatal disease has an illness. The illness is the patient's experience of being sick, like that woman I just used. Some patients with fatal disease will be up around and doing things until the moment they die. Really, with disease you couldn't believe anybody could function. They are diseased, but they're not sick. Now, towards the very end, everybody is sick. But in much of the course of the illness, relieving the illness, even with a disease, will make a big difference in that patient's life. The difference is the illness, which afflicts all, has a lot more to do with some than others. Most important, illness can be relieved. But to do that, physicians have to know what it is and how it manifests itself in that person. Why is that important to her? Well, we find out that the grandmother died of whatever it was, and that the whole family were around that bedside till the grandmother died because she was in awful pain. So why is this woman having trouble? Because the pain is awful? No, because that scene is the awful thing. And without relieving that scene, they say, what do you mean you relieve the scene? How can you relieve the scene? Oh, come on, we all know that. The stories are the stories about how you live your life. The story of the grandmother's illness is part of that woman. It's part of her until you make it not a part of her, which you can actively do. Most important, it can be relieved. For example, all persons with serious disease have fear, uncertainty, powerlessness, and doubt. They are symptoms of everybody who is seriously ill. Unrelieved, these are crippling symptoms, but when they're dealt with, which may take continuing effort, the person will be much better no matter what the disease. Illness is individual. What's important to one is not important to another, and so forth. And finally, my thing. You know, everybody has a thing. Oh, God, that's him again. Get him out of bed. The goddamn bed is so dangerous. Get him out of bed. Put him in a recliner alongside the bed. Get him out of the goddamn bed. You know how leaving aside the emotional part, you know, when you're sick and in bed, you're lying down and whatever you see, you know, like that nurse with the fist, her arm raised up. I'm going to transfer to the gurney in a minute, believe me. Anybody does that to me, I know she's serious. Anyway, get him out of bed. And besides which, muscles melt away in a few days. Those quadriceps you took so long to get, they're gone. Getting up from a chair without your hands, you know that test. You think you can do that now? It's only 3 days you've been in bed? Probably not. Probably not. You have to get them back. Anyway, when the staff and everybody, doctors, nurses, social workers, everybody, all the different kinds of therapists, occupational therapists, and I have a special warm place for occupational therapists because I think it's a wonderful field. When everybody is doing what they can do, illness and its effects are much better and patients are better off. Here is also where the family, understanding about illness, dedicated to the mission of relieving illness and guided by the staff can make a huge difference. It's a carryover from the past that if somebody is diseased, they ought to be sick. So the family makes them sick. They hover and they say, would you like that? Oh, you didn't finish. What's on your plate? Oh, please. Who gives a shit? They're going to die. What does it matter if they don't eat their broccoli? Who really cares? There is a caveat. Illness cannot always be removed or even greatly helped. Fatal disease is what it is, and it isn't anything else. It's fatal. And it's bad for you, and there are parts of it just cannot be relieved. That's just the way it is. The second step, geez, you're only up to the second step, and you got the second, and if I tell you there are 34 more steps, the second step in healing medicine is to return the doctor-patient relationship to the center of consideration in clinical medicine. Clinical medicine. Remember that the medicine that you all hear is about science. Clinical medicine is a special thing. We are fundamentally social animals. To think of ourselves as standalone individuals is a myth born of our drive towards individuality over the last several centuries. That's why people see themselves. In other cultures, people don't see themselves as standalone individuals. They always see themselves as connected to the family and so forth. They also see that if Dad and the brother died of a carcinoma of the lung, I'm going to die of carcinoma of the lung. And guess what happens? He does die of it. Now, it may be the fact that like Dad and his brother, they both smoked cigarettes from the age of 4, and that's why they're going to die of it. But whatever it is, that's the family history. That's the story, and they are a part of it. Our culture has numerous relationships. Mother-child, employer-employee, true friendship. Each one of them has rules, privileges, limits, and exceptions, and so on and on and on. And the doctor-patient relationship is one such relationship. It's very special, and as I said, magical, and it's present in every culture. So it's just something, and we know so little about it that it's amazing. It's really amazing. No patient, you know, that's the other thing. I just heard that. You know, large, big, amazing, and so forth. That's the other thing, that if we get rid of that sound in our ears, it won't hurt a thing. You never saw anything so big in your whole life. No patient should stand alone except rarely by choice or psychological problems. Particularly to confuse patient autonomy with singularity or aloneness is damaging to patients and doctors and to autonomy. You can't be autonomous and express yourself standing out there all alone. And if that sounds strange to you, well, you won't know enough. You can't express yourself or know what decision is really right for you if you're all alone. Where would you get the information on which to make that decision? Who can you trust if you're all alone out there? All decisions in all parts of the culture are made with other people. Somebody did a study of boat pilots on boats, and they make decisions. They call that decision-making in the wild. That was the name of the study. And they make decisions and asking people all the time about, what do you think, should I do this, and so forth. Medicine is just like that. People are just like that. You want to have help. You want to have somebody you trust. You want to have somebody you can call up, and so forth. So by putting a relationship and understanding that relationships are there is so important, and the relationship with the doctor even allows the physician to cause things to happen to or within the patient's body seemingly without obvious cause. Although this seems, as I say, strange in a rational culture, believe me, I can do things with you which you can't even imagine. And I'll do them and you won't even know what I did, because that's not your job, that's my job. Your job is to just do what I tell you, that's all. But of course, nobody does what you tell them, just like that. So my job is to find a way to make you do what I tell you and make it what I told you without having told you. And my mother did not teach me that. When the patient, and this is the other part of it, you should never think that relationships are one-sided. If the patient's endangered, so is the physician. And that sounds strange, because the guy is at one bedside, and in a few minutes he's going to be at another bedside, and she's going to be at that bedside and that bedside. Can they be endangered at all of them? Oh, yes. What do you think makes them worried all the time? Why? You don't know that, who aren't physicians, but the curse of physicianhood is worry. When I retired on July the 8th, 1990, when I retired on that day, and the worry was gone, it's indescribable. I wasn't worried. I wasn't worried. I didn't have to worry about anybody. There was nobody I could kill that day, you know? There was nobody I might have killed that day, and so forth. You can't, it's just only the doctors in this room. Really, there are some things that only them can know that worry never, never goes away until you quit. Boy, oh boy. Well, when the physicians separate themselves, which is common now, in the name of autonomy, it does not mean no relationship. You can't not have a relationship with the patient who you're taking care of. It only means a poor, disappointing, or failed relationship. And the relationship is an aspect of sickness. It cannot not be there. So if you do those things and it's a bad relationship, then you can't do what you ought to be doing to make that patient better. And that's just the fact of the matter. The relation is especially important in palliative care because by the nature of fatal illnesses, doctors have very few powerful tools, but none as powerful as that relationship. And it's also true of all medical care. Returning medicine to a heightened awareness of the importance of the doctor-patient relationship would be a large step towards healing medicine, increasing satisfaction and happiness among physicians. You know, when 50% of physicians are unhappy enough to consider quitting, that's bad for them. It's bad for us, too. That's bad, bad, bad. Sometimes, there'll always be some, because there are people who shouldn't have gone into medicine in the first place. But when 50% are like that, which is the way it is now, that's bad, bad, bad for all of us. The third important contribution of palliative care to medicine would be changing the focus of medicine and doctors from disease and disease-related abnormalities to a focus on function and the patient's ability to achieve goals and purposes, and ultimately to their satisfaction. As I said, When you go to bed and you've done what you meant to do, you go to bed and there's something hanging out over there, you're not. For 200 years, literally, the primary concern of physicians and medicines has been with disease. Why 200 years? It started in Paris. You know, a lot of neat things start in Paris. And this was one of them. And what happened is the Paris doctors and the Hotel Dieu, which incidentally, medical people can get a room in the Hotel Dieu, and it's much cheaper than a hotel room, and it's a great spot in Paris. You're right in the middle of Paris. The Cathedral of Notre Dame is right over there. And if you're especially unlucky, when you put your luggage down to get the taxi, somebody can steal it, which is what happened to my wife. And she lost her only small Chanel suit, which of course I'm married long enough to know is a big deal. Anyway, it's a great place, but they got sick people. They got the church out of the hospital. The nuns were no longer running it. The doctors decided who went in and who didn't. And they knew what the patient had symptoms were, and then they did an autopsy, and they had findings at autopsy. Incidentally, the autopsies were often done in a bed. There were often more than one patient to a bed, so I always wondered, was the other guy still in the bed? Anyway, and they found these things, and then, I don't want to make it magical, but you know, with time and understanding and the help of people who knew even more, a man named Bichat, who'd already done a lot of that, they began to see that with every sick person there is a disease in there. And that disease is why they're sick. And we have the medicine they invented still. Only we go down to a micromolecular level, and they only went to this other thing. Changing from that and understanding that what's important is not just the anatomical change in the bone or liver or whatever, but the loss of function of how the thing works. Because if it doesn't work, you don't work. And if you don't work in special ways. I mean, in other words, you can't go to work, you can't hug or whatever, you can't eat, you can't stand up, you can't do. That's how you know you're sick. Your doctor may know it by what's in the bone or the liver or whatever, but you know it because of what you can't do. And so changing from the disease as the center is fighting back. Changing from the disease, maybe I can turn it down. Can I turn it down? Has it got a thing on it? Everything's got a thing on it. This has not got a thing on it. But you can do this stuff. And I'll teach it. Now we know who's boss. Changing from the anatomical, that's better too, isn't it? Changing from the anatomical to the functional is a big step forward. In palliative care, where the diagnosis is not as important, there is no doubt about the loss of function. That person is in that bed. And when you start working on function and start working on what's important to that patient, the question of, oh, please, do everything you can, my father doesn't want to die. Well, I don't blame him for that, but that's not the way things are always going to go. But on the other hand, that makes it impossible. Now we have a fight between the oncologist and the patient's family. Either they do want to or they don't want to or something. When the real question is, what is it you still want to do? And let's see if we can't make that possible. They don't want to build a new Empire State Building. Why did that come to my mind? They don't want to do that. They want to make sure their brother comes. That's what's important. They want to make sure they repair something that happened 75 years ago. And you can help that. And so can the treatments help that. So, look. How about that? Higher. Lower, higher, higher, lower. That's the one problem with other people working in medicine. Anyway, the The point is changing that focus. That's not a small matter. That's a huge matter. And so we want people to function. They have to read, think, plan, move their arms or legs, walk, talk, laugh, love, some or all even or more of them, just like the rest of us. Functions involve the body and the person from the molecular to the whole person. You can't divide body and person when you consider function, because that this arm does this thing which looks so simple. You know, it's so, if it won't do that, or as my shoulder, because I have lost a piece of muscle in there, doesn't function as well as my left arm, the reasons for that are so, that's okay, are so complicated. Yeah, because you can't read this lecture. You want it up, don't you? Could I whisper and it would work just as well? Maybe that's it. Anyway, that change involves, it can't not involve the whole organism, the person, and even the social things. To be functioning, you're social. To be social, you can't stink. Because if you smell bad, you won't be a social person. Well, you know, there are things that stink. But there are also things you can do about it. Not always very good, but mostly good. So if you're going to be out among other people, which is what we do when we're a person, that means somebody helping and focused on it, not as a favor, but as medical care, whoever may do it. In the same way, if you can't type, even with 2 fingers, you can imagine how many books I've written like this. If you can't do those things, you're not you. You're you when you can do them. That's you. You know yourself not by the integrity of this particular muscle, but by what you can do. So moving the function to the center is a change from a primary focus on the body and disease to the person. This brings us to the fourth and final. Who's counting out there? I'm still doing all right? Great. That brings us to the fourth and final and probably most important healing change that palliative care can do for medicine. Put the person of the patient, the person and not the disease, in the center of medicine. Now that's very difficult. The care of the dying patient, the sick person, is most important. The problem of symptom control and dealing with illness require an understanding and working directly with the sick person. You think you can make things happen because you know how to do that? You can't make them happen unless that person wants you to. And often they don't, because doing what you want hurts. So somehow or other you have to take somebody for whom rolling over or sitting up is very painful and make him roll over and sit up. Because you were there and you said, you're going to be better. You're going to be better. We'll do it. Come on, just hold my arm. We can do that. We. Not you, not I. We. Because when the relationship is there and the person is there, we're we. We can always do more than I or you can. Anyway, what the person is. Yeah, that's right. That's right. And it is right, too. And the word we, instead of somebody standing, this is the point of the lavalier mic, it took long enough to happen, but instead of the person standing at the end of the bed and saying, listen, Charlie, you got to get out of bed. You just got to do that. Doctor, I just can't sit up. I get so dizzy, I can't sit up. You got to do it. The nurse will help you. You'll see. That's one thing. And the other thing is, we got to get you out of bed. We're going to do that. I can't do that. It hurts too much. Oh, I know that. So I'll tell you what. We'll make sure you get some morphine about a half hour before you have to get up. And we won't give you so much that you're all fuzzy. And then we'll sit up and you'll see. I'll get dizzy. We'll hold you up until you're not dizzy. Your body knows what to do. It's been lying down so long that that thing it knows what to do is going to sleep. So we got to wake it up, and then you'll stand up, and you won't be dizzy. And you walk, and then we'll walk to the nurse's desk. You don't think so? I promise you. Doctors never promise. I promise you. We're going to walk to the nurse's station on Wednesday. But this is Monday. Okay? You're going to still be alive. We'll walk to the nurse's station. Doubt, fear, powerless, and uncertainty afflict every person, but they're different in different persons. And when you work on those things, you change somebody. One time when Pat and I were in San Francisco, as a matter of fact, I use hypnosis a lot. So when we were at a hypnosis conference, and I think it was powerlessness. You can do this. You can say to somebody in a trance, in a few moments you will feel totally powerless. How does that feel? She thought it was awful, and it is awful. If I go, whoop, and you're powerless, nothing. That's horrible. Half powerless is horrible too, and so forth. Those things are changed by changing the person. They're different in every sick person, and they're different, and finally meaning of events. What things mean to the sick person that are the trigger for fear and uncertainty, doubt, and paralysis. Meaning is personal. In the 13th chapter of the second edition, that sounds so dumb. In the 13th chapter of the second edition of The Nature of Suffering is a chapter of mind-body. I only did that because I wanted to get a second edition, and the editor said, well, why don't you write something about mind-body? And I said, I don't want to get into that. You get into that, you never get out. She said, well, just write what you know and see what comes out. And what came out was the meaning is the medium between the body and the person, and between the person and the body. What things mean to you, and what you know to be the meaning has an impact on what you can do again. Oh, and I'll tell you another thing which has got me a little bit, paramecium, under a microscope. If they go to bump the wall, they turn around and go the other direction. Why do they do that? Can there be meaning? I mean, why does the dog run away from there? Because of what the thing means. So the dog has to have a system of meaning too. Oh, don't start down that road. Because if you start down the road, like me, you won't die when you're supposed to. And that's, so that's probably not a joke. But anyway, my wife doesn't think it's a joke. Anyway, think about it, meaning. But for patients, the meaning of things is what counts. That woman, the doctor said, well, it may be worse than we think. It's the meaning of that phrase. Does that mean, like one of the patients I have in something I wrote, she says, it's because everybody deserted her mother when she was dying. Which that's what she's afraid of. It isn't the death, it's the desertion of everybody. And you don't even know that because you didn't ask. What does that mean to you? So there we are. There we are. So it is with sickness, the meaning of events, and all of that stuff. Then bioethics and autonomy begin to have some real stuff. Finally, the patient-centered movement of these last dozen or so years had made all institutions proclaim that they're patient-centered. Well, that's good. That's what signs are for. But what I mean by patient-centered is different. Who the person is has a demonstrable effect on what disease they get, how it shows itself, how the diagnosis is made, what treatment they get, how the treatment is tolerated, and the outcome. If that depends on the person, then don't you think that the person is centered doesn't mean just, we'll do whatever you want, Mrs. So-and-so. It means understanding those things so you can understand why this person is that way. So person-centered should be in removing, changing, and dealing with impairments of function that keep the patient from achieving the goals and purposes that are well-being. Well, I should say, for me, for everybody's definition of sickness is you're sick if you have a disease, or if you're sick, you have a disease. And you know, if you can't find the disease, then we put doubt on your sickness. It's not you that counts, it's whether we find your disease or not. And without somebody saying, listen, if the person still thinks they're sick and you can't find a disease, that's the illness. Treat it. If the illness is, I know I'm sick, that's the illness. Treat it. Any case, when will all this happen? I believe all these changes will take place, but when? One advantage of being old, and there are many, I might tell you, there's some very big disadvantages too, but one big advantage is that I know how long things take. I used to think, you know, when I wrote the paper on the nature of suffering, and it got accepted in the New England Journal, which was a freak, but wonderful. I thought, well, you know, now suffering. It took 10 years before people began to pick up the concept. Not in palliative care, it was picked up right away in palliative care. Began to pick up the concept. And it's now, what is it? That was 1982, 20 years, 30. Now 35 years, suffering is now a part of me. So I would say it took about 25 years. And it's a very straightforward concept. Things take time. 10 years, 20 years, 30 years, 40 years. What difference does it make? They're going to live your life. I always say to patients, what do you care? You're going to live your life anyway. Things take time, but they don't happen by themselves. And it isn't like, now it isn't, and now it is. That's not the way it goes. It goes, now it isn't, and now these people do it, and these people do it, and these people. And then this one starts writing, and this one starts writing. That's very different. And who are the ones who make these changes happen? We. We make them happen because we know how to take care of sick people. And we know what's the center of the whole of medicine and what the center of the responsibility of a society to its sick are. Take care of them, even unto death. Thank you very much. Thank you. Isn't that nice? Thank you very much. Thank you. Listen, I'm a very emotional person. Don't do that. Don't do that. Don't do that. My children were asked, who cries in your family, your mother or your father? I don't cry at bedsides. I don't think it's right. I cry at movies. I cry. Somebody makes a pass in football that's unbelievable, makes me cry. Anyway, thank you very much. That's very nice of you. Who's running this thing? Yes. Yeah, because that's the part I really like. Yes.
Not a question, but I just want to thank you for being a plug for occupational therapy.
Oh, see, I think you guys are neat because you do everything. Somehow or other, they don't tell you when you, whatever you do to get to be one, they don't tell you you have limits. And so you do things that you're not supposed to do and they work. And I think that's wonderful. I really do mean that too. I really think it's a neat specialty. Okay, function, right? It's a wonder it took so long for us to find out, don't you? Don't you think? You know what took a while? Yeah. Although if you read what I write, and I don't, but if you read what I write, the word function appears very early. It starts appearing. That's because I'm a process philosopher. Philosopher? Well, I've got people who like philosophy. It isn't because you read it or anything like that. It's because you have a genetic defect. And if you have that genetic defect, you spend your time reading things that other people think are nonsense. Anyway, Alfred North Whitehead is a process philosopher. That means the change through time will change through time. Right? Yes, whoever, yes.
Hi, good morning, Dr. Cassell. Thank you so much. That was beautiful and inspiring and wise beyond measure. Unfortunately, many of us now practice in this very business-focused and money-driven world where we've had to establish the importance of palliative care through science and through validation, and that will likely continue. Can you give us any guidance on how best to use that science as we move forward into the next decade so that we can strengthen the role of palliative care in the landscape of healthcare in general?
Well, I mean, actually at the bottom, you go science that are evidence. We're talking about evidence. Evidence matters. And that's just it, the way it is. Evidence matters. So we are able to produce evidence. And we're able to follow the rules and produce evidence. That won't be everything, but it'll be some things. You know, some drugs are better than other drugs. They are. And sometimes they're better for one person, better for another. There's evidence about that, and we can produce it and follow that evidence. It's very hard, I believe, to go against the evidential findings of a good study. If the study applies to your patients and you want to do something different because you have a feeling that it's better, I think you shouldn't do that. You have to tell us why you're doing that. And that part of science, I think we can follow. The fact that it's hard to get evidence for a lot of our things, that we have to design studies differently, that's a different matter. And that I think we're just in the beginning of understanding that we have to figure out a better way of making good, solid, reputable, and replicable evidence. Does that answer the question?
Yes, thank you.
Right. Don't quit. You know, this writing the thing is work. This is fun. Yes. Yell. Hi. Now you know, right? Now you know. She kept asking me, what are you going to talk about? What are you going to talk about? I said, you'll see.
You're funnier than I thought. You were funnier than you were out there.
Well, if I was really mean and nasty, I'd say, but they didn't pay me out there. They're paying me in here. Yes.
Hi, my name is Elizabeth. Thank you for speaking this morning. I have a question. I work with several people with severe addictions, and as you're talking, it struck me that many of the areas that you're describing could actually very well be used in the world of people dealing with addictions. Is there any thought, has there ever been thought about using palliative care with people with addictions?
Well, addiction is a complicated thing, and everybody knows that. But there's some things about it. For one thing, when I hear all this fuss about addiction, all it means to me is it's going to be harder to get medication and treat people. That's what's going to happen, is it's going to be harder to get your local pharmacy to do this, that, and the other thing. But leaving that aside, although you can't put it aside, see what I would do is I would treat a patient, and then whatever they didn't use, I would scoop up and put in my office safe thing. See? And then with the other patient, I would give them that, and whatever they didn't use, which I prescribed, I would take back. And pretty soon, we could have had quite a party in my place. Unfortunately, morphine makes me vomit, so I can't. But anyway, I think we have to be appropriately aware of addiction. But I also have to say, listen, what is this with this big thing now? Why is this happening now? You know, these drugs have been around a long time. We've been prescribing a long time. I have a, you know, everybody has a nutty thing. My nutty thing is oxycodone. If long-acting oxycodone and long-acting morphine were taken off the market, I think it would be a good idea. Because there's something about those drugs. But that's me, and I have none evidence for that. So, but I think that the issue is we have to be aware, and we have to be publicly aware, and we have to be with patients, because what happens is then patients don't want to take the medication because they're afraid of becoming addicted, or that people in the family will take their medication. We have to address it, be aware of it, and not be above it. No, it's not answering your question, so ask the question again.
I'm actually thinking of people who are using street drugs, heroin, other drugs, and in their treatment. I'm actually thinking whether or not palliative care could move over in that area and provide some treatment, help, relief.
When I was a house officer, we didn't call them house officers either. When I was a resident, Bellevue was a center for addiction, you know, and the patients would get their heroin in the psychiatric hospital, and they would say, "Doc, you can get this stuff in heaven." I didn't understand it then. I really don't understand it. I mean, understand it. And I know there's such a thing as addiction and so forth. So I think if I were working now, I would not stop giving people medication, because I've always done that. I think that's the right thing to do. But I think I would watch that, the amount in each prescription more than I did then. You know, making a month's worth then I did without a thought. But now I think I might be careful. And I think I might, you know, it's personal. I think I might want to find out more about it. Instead of saying, oh, you don't have to worry about addiction. Yes, you do. I think I would go after it. And that's what I think you have to do. You have to go after it. What's making this happen? Why is this happening? And I think we could find out more. I know it's an inadequate answer, but you know, somehow or other, every time you address addiction, you give an inadequate answer. That's pretty cop-out, isn't it? Yes?
Thank you so much, Dr. Cassell. I was struck by your sense of immense relief when you retired, and makes me think about my own experience driving home from the hospital every day on my bicycle and pulling over all the time and calling the hospital back because I realized I made a mistake or I forgot something or I wanted to make sure of something, but that worry process. So I'm just wondering if you now have any perspective that you'd be willing to share on the nature of provider suffering and how we can try and avoid that for ourselves.
Well, I don't want to put down my dermatologist from before he retired was wonderful, and the reason he was is he used to be an internist, and he quit that because he couldn't leave the hospital because he was always scared about what might be happening behind him. I think you first of all, you have to know it's common to all of us. That's the first thing. Once you know that, that makes it a little easier. It doesn't make an individual worry easier, but so forth. The second thing is you have to know, you know the evidence, you've read the literature, you know your patient, you've done what you think is right, you asked for help when you needed it, and then you wrote an order, and that's it, you did it. Now go home. And if you've done those things, that is, you have fair confidence that you know what you're doing. That's why you have to stay up. I mean, keep up with it. If you have fair confidence that you know what you've done, and in doubt you've asked other people, and you've looked at it from this side and that side and that side, then you have to go home. And if you can't do that, change to pathology. You know,
Thank
but
you so much.
even they sign their name at the bottom of a report, right? Like the radiologist signs their name at the bottom of a report.
Thank you very much for a very interesting talk. I just want to address that issue of the addiction. I think that most addiction teams now follow the palliative care method. They use a team approach. They look at the psychosocial situation of the patient, the functionality of the patient. You can't treat addiction without looking at all those other issues. And I think that, what I've always trained people is that, the palliative care model that we have with the patient in the middle and dealing with functionality and dealing with symptom relief, why do we wait till people are really sick before we do this? This is how all primary care should be.
You brought up a word. I want to say something about teams. That's a word now that everybody uses. The team is doing this, the team is doing that. So you can't say anything about teams. It takes many of us to do the work we do. Teams don't take care of people. People take care of people. A team is too often an excuse for nobody being the central responsible person. And then the word team is a bad word. So I think you have to understand it's wonderful that it takes more of us and we have these skills, but a person takes care of a person, not a team. You can boo. Okay, right? Thank you very much. You're a wonderful audience. You're really a wonderful audience. Thank you very much.
And you're still going to be around today.
Yes. Oh, yeah, I'm not running away because where would I go? I can't get up to my house.
I don't know how to follow that. Just to let you know, you have a 15-minute break, and then we're going to go into breakout sessions, and you have the information right here in the front of your program. Thank you.
Yeah. Yeah, you can have it.